It's Dr. Pete at the Ascend Antibiotic Stewardship Collaborative. And today we're going to talk a little bit about how to talk about stewardship with residents and families. So let's begin by reviewing the number one main idea of our protocol, and that is touching base with the number one public health problem in America and the world today, which is widespread antibiotic resistance. And the main idea of our protocol is that the root cause of antibiotic resistance is people receiving antibiotics for infections they do not actually have. And as Dr. Darasinski, the head of stewardship at Stanford, says, we are awash in a sea of antibiotics. That's a pretty good way of saying it. The second main idea of our stewardship program is that we do antibiotic surveillance based on the clinical syndromes and not on the classes of antibiotics. Classes of antibiotics are things like penicillins, cephalosporins, the mycins, gentamicin, kanamycin, all that. So people sometimes do stewardship by collecting data according to antibiotic class, and that doesn't give you any real action points. Whereas if you focus on collecting antibiotic data, utilization data by clinical syndrome, it works a lot better. It points the way to the next action item. So the two main syndromes that we focus on are, number one, presumed urinary tract infection, which is, as you probably know, the commonest reason antibiotics are given in post-acute care, and for that matter, probably in acute care as well. And the second syndrome, close behind, is presumed pneumonia. And these two syndromes, if you get your arms around those two syndromes, you're probably hitting more than 90% of the reasons for inappropriate use of antibiotics. So that simplifies the issue a fair amount. And just before we go too much farther, in a kind of a sidebar, I want to make clear, in general, we are discouraging the use of empiric antibiotics. That is to say, antibiotics that are based only on a presumed infection in low likelihood clinical scenarios. So you need to be using a formal case definition for both, in our case, UTI and pneumonia. And these are in separate areas on our website, and you've been exposed to both those case definitions before in the way that we do surveillance. So the other way to think of empiric antibiotic therapy is any antibiotic therapy that's not guided by a diagnostic test. And as you know, our case definitions for both UTI and pneumonia have both a clinical symptom part and a positive diagnostic test part. In the case of urinary tract infection, it would be a positive urine culture, more than 100,000 colonies of whatever on a single organism, usually E. coli. So what we're out to really discourage through the main ideas of our program are to move away from empiric antibiotic therapy and only give directed antibiotic therapy based on a case definition. So when we talk about stewardship, there are three main targets of the people we want to put our arms around and bring them into the fold of effective antibiotic stewardship. The first group, of course, are the prescribers, the physicians and prescribing nurse practitioners. And the next group of importance is the nurses and other caregiver staff. A nurse colleague of mine many years ago told me that she thought that 3/4 of antibiotic prescriptions in nursing homes and other post-acute facilities was due to what nurses say and how they say it to the prescribers. That's a pretty good thing to keep in mind. And then the third group, of course, our targets of stewardship education are the subject of today's talk, residents and their families. So what's the real problem there? One of the problems mainly is the families and residents pressure prescribers and the nursing staff to give antibiotics. And this is the residents and the families frequently have, like the general public, outmoded concepts of when antibiotics should be given. The most common one is people taking antibiotics for a viral upper respiratory illness. And as we all know, antibiotics don't work on viral infections, and they don't prevent a bacterial infection. So those kind of concepts are what I'm pointing to as outmoded concepts that we want to uh, deal with. So how do we start a conversation with either the residents or the families? And I've got a list of them here. And the one at the top is this is a conversation that you can have at the when you're admitting a patient to the facility. That's the best time, when you can talk to the families and the resident at the same time and make the point that antibiotics are powerful drugs when they're used for the right reasons. And taking antibiotics when they're not needed can cause more harm than good. And at the end of our references for this little talk today, there's a one-page item called "Are you sure your loved one has a UTI?" And that's a very useful thing to read over before you have a conversation with the resident or the family. The next idea is that normal resident bacteria are needed and they cause no harm. You know, in the early days of antibiotics or microbiology, actually 100 years ago, people thought that every organism that they cultured was a pathogen, and that was how it was in the very early days, that most antibiotic or bacteria that you isolated were pathogens. But now we realize that we have, as humans, we have an intimate relationship with bacteria, who, and the numbers of bacteria in and on our body seriously outnumber the number of human cells. So they are with us all the time, and we couldn't live without them. A related theme on that idea is that asymptomatic colonization of the urinary bladder is very common in elderly people, especially. Women often have, when you culture their urine, they'll have 50,000 or even 100,000 colonies of E. coli, for example, and they'll have no symptoms. And if you just use the culture as the definition of UTI, you're going to be treating people who are just asymptomatically colonized. And the final point that I want to make in conversation starters is to reassure people that watchful waiting, like giving fluids and waiting for what happens to the minor symptom like confusion, is still caring for the patient, and it's still treatment. So that's a worthwhile point, so that people don't think that because we just give fluids or we don't appear to be doing anything, that we're not caring for them. It's not so. So when are the best opportunities to have the conversation with a resident or the family? The best opportunity is right at the bedside, when assessing residents on admission particularly, and anytime they have a symptom of any kind and or the family requests it, so that you can have a conversation. That's the best opportunity. And the way to start there isn't, they'll usually say something about, their mother, their father, or whatever has had urinary tract infections in the past. So the place to start with them is on the theme of that asymptomatic colonization of the bladder is common and is often confused with a case definition of a urinary tract infection. Another opportunity is at the part of the admitting package, as I've said before. That's a very excellent opportunity to have the conversation with the resident and the family about the new ways that we use antibiotics now, not like we did say 20 or 30 years ago. And the last best opportunity would be if you have a resident council or some gathering of residents or families. Sometimes facilities do evening seminars, that kind of thing. That's a good opportunity to get the principles and the main ideas of our antibiotic stewardship program out there in front of people. So in order to be doing the antibiotic stewardship protocol most readily, there's things to do before requesting a diagnostic study. The idea of waiting before you order a diagnostic test is often referred to as antibiotic, or rather diagnostic stewardship, in addition, like the other side of the coin from antibiotic stewardship. And they're both very important. So the bedside assessment is important, and after you do that, the next thing is to have a protocol for urinary tract infections, pushing fluids, doing their vitals, checking them every shift. And there's also a pneumonia protocol where you give them a cough suppressant medication and monitor their vital signs. Both those protocols are elsewhere in our materials, and you can refer to those. So in summary, family members and residents are important care partners. Like the best care occurs when there's a partnership or working together with the residents and the families on the goals of best care. That is, the safest care happens when staff, families, and residents are aligned on stewardship goals. And lastly, the additional resources in the references attached to these slides, and you can find them also on our website. And that's a wrap, James.